It looks like we are ready to go time-wise and tech-wise, and so we'll call this meeting to order. I'm Karen Hiller, the chair of the Topeka City Council's Social Service Grants Committee. Today is October 29th, 2020. We're at the Law Enforcement Center classroom at 10 o'clock. And we are having our second meeting to review how the social service grant process went last year, with in mind that a charge of this committee is to recommend to the City Council what the structure of the social service grants program would be for next year. So our charge is to do everything from recommend whether we should continue outsourcing to the specifics, as the committee has done every year, of looking what the priorities are, the calendar, and details about grant amounts, how the application would be formed and how the decisions would be considered, and whether a scoring process or some other system would be used to make the grant awards, with in mind that there would be a very tight system that was well managed, that was transparent, and therefore when the decisions got made, they would move forward without any problem. So we have had tremendous participation by the committee as well as the agencies, and are ready to go into round two. And with that, we have one committee member online virtually and one in place here. So would you please introduce yourselves?
Mike Padilla from District 5.
Christina Valdivia Alcala from District 2.
Thank you so much. And we've got, let's see, one person from United Way, and 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, about a dozen social service agency folks, and our budget director on deck. So thank you so much. With that, our first order of business is to approve the minutes from the October 5, 2020 meeting. Do I hear a motion to approve?
So moved.
Second.
Moved and seconded. Any corrections, adjustments, comments? If not, all in favor say aye.
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 Aye. Opposed? Minutes are approved. We will move forward to, we have two agencies that have been, we debated the term grandfathered last time, but anyway, have been allowed the last few years a higher maximum grant amount than the other agencies in the competitive program. And we heard a little bit from one of them last time, but the decision was to just have a program overview from each of them, Positive Connections and Healthcare Access, with in mind that we are reviewing whether that extra money should continue to be earmarked for those agencies, or whether they would be in the same competitive pool with the same maximum as the others. With that, Positive Connections is here.
Yes.
If you would come up to the mic and introduce yourself.
Thank you.
Thank you. My name is Kathleen Link. I am the Executive Director of Positive Connections. And what Dustin has just handed out is just a little information about our organization and the people that we serve. My stand here today for the reasoning that we need to stay grandfathered in is that's basically one case manager on our payroll. We have 3 case managers total. We have a total of 198 clients, with 125 of those reside in Shawnee County in Topeka. Why it's so important for our case management program is many research studies have shown, now proven beyond a shadow of a doubt, that persons living with HIV who stay in care, take their medications effectively, have no risk of transmitting the disease. So that's very important. Our case managers, they're medical case managers, they make sure that our clients stay enrolled in services to get their medications, their lab works, everything that they need to do to stay undetectable. Undetectable means untransmittable nowadays. Not nowadays, but they just proved that 2 years ago. The money that we get from the city It basically pays for many different things, but what it totals up to is the salary of one case manager. Several years ago, we lost a lot of United Way funding. So the city is our second highest funder for our grants. We also, besides provide case management, we provide bus tickets for our clients to get to and from their doctor's appointments. We provide a food pantry. That is very important. We have many clients that access that. With the COVID-19, we've had thousands of interactions with our clients, and we have given out over 40,000 pounds of food to clients starting this year alone. We do health, education, risk counseling for our clients to let them know if they stay undetectable, that means they're untransmittable and that they need to stay on their medications. Some clients will want to go on a vacation from their medications, which the case managers are very adamant on telling them that once you go on a vacation from your medications, that medication's not going to work again. So you can build a resistance. Our case managers are crucial for the 125 clients that we do have in Shawnee County. Do you have any questions?
Madam Chair,
Please.
just a quick one. Thank you for coming here today. How many case managers do you have?
We have 3 case managers currently. One case manager only covers the Manhattan, Riley County, and Geary County area, and then 2 case managers that cover our Shawnee County area. We cover 17 counties, but most of our clients, well, as you can tell, 125 of them are from Shawnee County.
So you cover 17 counties?
For case management services, yes, we do. We are the only freestanding HIV case management organization in Topeka and in Kansas, basically. The rest are part of KU Med, and then there's like Douglas County. They're covered under the health department.
And about approximately how many, I guess, clients would each case manager have?
It depends. Mike, he is our case manager that is in Geary County and Riley County. He has about 60. And then the other 2 case managers are split, so they're running an average of about 70 clients, which is a lot.
Yeah.
You say it's a lot. Oh, I'm sorry. Go ahead, Christina.
Well, no, that's okay if you want to continue on that thread. I
Okay.
just have questions when you're done.
Okay, I'll turn to you. You say it's a lot, but a caseload of 70 of grown-ups that are otherwise healthy sounds like not very many. Help me with that.
Our clients are very dependent on us for our services. We don't just help with HIV, we help with housing. Like I said, we do emergency financial assistance, so we help with rent, utilities, stuff like that. So all of our clients are pretty much, their hands need to be held by us to basically keep them in services. The majority of them do. Our case managers have to document every interaction with a client, whether it be a phone call, an in-person meeting, a call to a doctor concerning the client. So with just 2 case managers covering Shawnee County, that's quite a few clients for them to be juggling. We were down to 2 case managers for a couple of weeks. We had 1 case manager leave us. We've just now, within the past 3 weeks, gotten a full staff.
have some experience doing that myself,
Yeah.
documenting and so on. We had much bigger caseloads, but not as deep an involvement as it
Yes,
sounds like.
our
you
case
all.
managers are very involved with our clients.
Okay. Councilwoman?
Thank you, Chair. I do have some questions. What is the current amount that is grandfathered for you all? Can you remind me of that?
35,000.
35,000 versus a 25,000 max that can be
Yes, ma'am.
achieved if you were put back in the regular pool. And with this 40,000 pounds of food so far that has been given, is that for all 17 counties that are served, or is that mostly for Shawnee County, or how is that breakdown?
Most of it is for Shawnee County. Probably about 10% of that is for Geary and Riley County.
And how is the food? How do you obtain the food?
Currently, we are providing boxes to our clients. We used to have them come into our office and shop. That way they would get the stuff that they knew that they could use. But with COVID, we have just started doing food boxes. But they
Okay.
get probably 3 boxes of food every month, along with insure and bus tickets.
Okay, and I guess I didn't phrase that correctly. How does your organization obtain the food for the pantry?
Oh, we purchase it from harvesters, most of it. Reesers, Cares, they donate quite a bit of food to us as well. And then what we cannot purchase from harvesters, we will go to Sam's Club or Walmart or Dillon's and purchase that. The milk and eggs have to come from Dillon's. We purchase our hamburger and protein items from Leonard Meat.
Okay. My question too, because I'm not familiar with other organizations in other states or another part of the counties that you do not serve, your verbiage is that there's a lot of hand-holding that goes on with your organization to the clients that you serve. Is this usual for other agencies like yours to have this? I guess I'm trying to understand. It sounds to me like with those that you serve, everything is very compartmentalized specifically to meet all of their needs. And while we know that HIV is being able to be addressed with the phenomenal amount of medications that are out there now to assist them with their illness, I want to try to understand, is everything that you provide what you see in similar organizations like yours?
Yes.
I guess I have concern about the hand-holding part of it. I want to flesh that out a little bit more.
Okay. Yeah.
Sorry, Dustin Famatter here. I'm the assistant director, and I have a lot of agency with this as well. Most of our clients, actually 95% of our clients, are under the federal poverty level. Because of that, and because of their ethnicity in many cases, most of our clients are Hispanic or African American. Because of that, they have quite a few barriers to care as far as physicians being upfront with them, or sometimes there's a language barrier. Because of our care and our services, we can make sure that that advocacy is given to them directly. So while it is kind of a hand-holding, it's also because they need it, because they're not getting it elsewhere, and because many doctors, they hear the word HIV and they automatically have that taboo. And then to see someone who's African American or Hispanic, that adds that taboo. So by us stepping in and having that individual case manager to advocate, to call the doctor for them, it helps with that quote unquote hand-holding as far as making sure they get what they need.
Okay, thanks, Dustin. I would also ask the question, what is the percentage of those that you serve, the breakdown on ethnicity or race?
Sure, I can email that to you. That's what I gave out. Hispanic is 11% of our clients. African Americans is 16%. Native American and Asian is about 2 to 4%.
And then the rest are white?
Yes, 49% are white.
Okay.
Um,
And I would also ask, are you seeing, in those that you serve in Shawnee County, that you said about 125, is that number of HIV that are coming to your organization, is that kind of leveled off? Are you seeing an increase or a decrease, or how has that been looking, say, over the past 5 years?
So over the past 5 years, our basic case management load has stayed pretty close to the same. That's because we've lost people. Some people moved away, others have passed away. But it stays very similar. We have had a few increases over the last probably even 6 months. I also deal with prevention, so I'm the one that gets to tell people they're HIV positive. And then normally my next thing that I get to say is, but don't worry, we're gonna take care of you for the rest of your life. And so that's why it's so important to have case managers, so I'm not a liar.
Right, and tell me that also, do you actually do the testing there then as well?
Yes, that's where I'm mostly over is the prevention. I not only do the testing in office, we do outreach. We go out into the communities wherever people are, and we test them there on site. So basically anyone who wants to get tested, not only do we test them, then we take them into services. We take care of them forever.
Okay, and I would also like to know that kind of hand-holding concept that you have and that you're explaining. Do you find when clients go outside of the system, stop utilizing your services or services similar to yours, that there is a greater chance that they will stop using their medication, or is any of your services surrounding making sure that they stay on it? I know you said some people want to take a break from it, but do you find that that is a legitimate concern that you have to continue to work with?
Absolutely. The CDC actually published a study earlier this year that clients who are not in case management services, those that are in case management services like us, 95% of them are in care and stay in care. Whereas the other 5% of people who aren't in care don't stay in care and they fall through the cracks, so to speak. And then they're more likely to spread it to others.
Okay, and additionally, when you say that y'all say that you are the standalone entity, and you say there are other agencies like KU Med, et cetera, again, I'm trying to get a sense of how you all differ than, say, a program with KU Med. I mean, is there more ongoing, delving deep kind of case management, or versus kind of skimming the surface, approach? Not to slam anybody, but I'm just trying to get a feel here.
So we are the only one in Northeast Kansas. So KU Med, they have a bit of a program here in Lawrence, but their main focus is down in Wichita, and they deal with the other half of Kansas. So we're really the only ones for this part of Kansas completely.
And we,
Are your programs kind of modeled, that kind of hand-holding approach and that intense amount of care that you provide them? Is your program modeled for other states that have similar programs?
actually, our program has been, that we are the ones that are modeled from. The HRSA has come in to our offices several times, and they take our procedures and pass them on to the other organizations like ours. So we are the front runners in our field.
Okay, thank you, Chair.
Thank you. Couple more questions, because I'm looking at the data sheet, and I think maybe we scrambled a little bit in terms of ethnicity and income between Shawnee County and your total. It looks like Shawnee County is only 12.6% Hispanic and only 8.5% African American.
So that's not our people, excuse me. That's all of Shawnee County. I took this directly from the Health and Human Services information based on Shawnee County completely. That's just the makeup of Shawnee County.
Oh, that's Shawnee County. That's
Yes.
not your clientele.
That's not
Right.
our
in Shawnee
clientele,
County.
sorry. Uh-huh.
Okay, because what I was doing was then taking the ones that were listed below as if they were the non-Shawnee County.
Yeah,
Right.
no,
So, okay.
this is all of Shawnee County. Not everybody that has HIV is in our services. We do have, income levels, and there are people that don't qualify for our services. So this is the total of Shawnee County, which isn't just the total of our clients.
Okay, so of yours, you haven't broken out the Shawnee County demographics versus your total clientele demographics.
Correct.
Then, for us anyway, I'm sure you have it. And the income as well, it looks like half of your clients are making, close to half are making over 35,000 a year, and then close to half.
That's not
Less
our
than that.
clients. That is the total of Shawnee County. The total of people living with HIV in Shawnee County. If you would like the demographics of our clients, we can definitely put that together for you.
Okay, so when this chart that says client ages, client gender isn't your client?
Yes. This is our clients.
Yeah.
Oh, it's I'm sorry. I apologize.
Sorry, I know you can get nervous too, so it's okay. You're just
Go
trying to
ahead.
track.
Okay, so yes, this is broken down by our clients. So as you can see, 44% of them make between $0 and $9,999.
I was crossing over the blues.
Okay?
So, thank you.
Uh-huh.
I was giving them the 35 to 49.
Oh, no.
Okay,
Yeah.
going the wrong way on the circle.
Yeah, only
Okay.
about 20% of our clients make more than $35,000 a year.
Okay. And, all right. And is the race and gender split fairly similar between Shawnee County and in Fort Riley and,
It's actually very, very close down the middle.
okay,
Mhm.
okay. There's another question, and that's, a couple more questions. How many people do you have total on your staff then?
8.
8. So it's you as director and assistant director, and then we've got 3 case managers, and then,
2 prevention, and then 1 program assistant. But the grant that we are speaking of only provides for case managers. The case management and us. It doesn't cover any of the prevention or the program specialist.
the grant that we provide you?
Yes.
You mean? The other question I had was, I imagine you're the envy of other agencies in some ways. I'm not familiar with anybody that buys food. Where do you get the funding to purchase the services?
We get that through KDHE, Kansas Department of Health and Environment.
And the same for your cash assistance on rent and things like that? Where does
That comes from another grant called Broadway Cares.
Okay. Wow.
We also have another grant that we get the food assistance from. Not all of the food assistance comes from KDHE. We get another one from KCTH, which is Kansas Care Through Housing.
With all the services we provide, we've had to be very creative with the many different grants we get.
Well, it sounds like it. Wow. Okay. So, back to these numbers then. How many, you've got 2 prevention people in addition to yourself that are all doing outreach then?
So we have one person who it's his sole job to leave the office and go and do testing outside of the building. Then we have another person who it's her sole job to go out and teach in the community. She goes to high schools, colleges, prisons, rehab facilities, and just does sexual education to prevent this. And then my job is to oversee them and to do testing in the office and help Kathleen when she needs me.
What's your total agency budget?
Oh gosh, I should have had that number. 365, I do believe, 378, something like that.
Okay,
Sorry, I don't have the exact number for you.
that's okay. And that includes the food and rent, and that kind of cash assistance or?
Yes, ma'am.
Purchased assistance as well? Okay. Other questions?
Chair,
Mm-hmm.
I do have concerns about the food pantry, though, I must admit. I don't know, the buying of food and then giving it back out, I just question that a little bit. And while I think the services are very, very important here, I think we should seriously look at some possible adjustments, even if it's, a $10,000 reduction, but I don't have an issue with grandfathered or whatever verbiage we want to use to programs that we know are serving a marginalized section of community. I do think, though, that the amount that, once they meet all the metrics is, right now at 35,000, I do have some doubts about that. And it is because of the increasing need in other areas I think we're gonna see in the coming years, but that's my input.
Thank you. I think that obviously we're going to address the issue on both of these agencies probably today, but I'm also finding that this is very informative for us, and thank you in many ways for being our models to talk with, because one of the things we are going to be talking about today is what we ask for in the applications, looking at total agency, not just at program, and so on, because that has not been done in a number of years in the social service grant process. And so this is sort of informing us in a bigger picture about our tasks for the day. So thank you so much for that. Oh, another question?
Chair, I just want to follow up on something. I want to make sure that at our last meeting, I was the one that brought up the idea of maybe using a different term than grandfather. I didn't mean to give the intent that I didn't like the idea of grandfathering. I just wanted a more definition of what it was.
Right.
And I think it was cleared up that even though an agency may be grandfathered, they're still going through a process that they have to provide all the information, all the data, everything that anyone else would do as well.
Exactly.
It's not just handed over.
Exactly.
And I have to admit that I haven't had a chance to really get down and visit there at Positive Connections recently. I have done it before with another council person, and I was impressed by the number of services that they provide, especially with a community that often, I believe, is kind of maybe overlooked in what we address as a health issue. For me, it's just the old adage of ounce of prevention, and I think that these are well-spent dollars. As I understand it, the dollars that are being asked for here are not used for the food purchases. This is for the case manager. And I think that case management, I would rather say hands-on or whatever, rather than hand-holding, but that first-hand, hands-on person who manages the clients at a personal level that they do, I think is important. And so for me, I don't have any issue with the food at all. And I think my focus is on providing for that case manager, and that's because that's where our dollars are going. And I would not be leaning in the direction of reducing any amount of the request at 35,000 at this point.
Okay.
Thank you.
I mean, part of the reason that we are examining these two in particular is that there were reasons put forth years ago now as to why it was critical for that organization's survival to have that higher amount of money. And if I recall, in the case of Positive Connections, the whole HIV world, it used to be called the Topeka AIDS Project, and the HIV world had changed, and instead of it being a deadly and unmanageable and frightening specter, if you will, not that it still isn't, but things had changed substantially and the funding had changed. And a prior council, and I think Corey was here, so I'll watch for her nods, you know, was advised that it was critical as the match money to get the federal grant. And I don't know that anybody ever asked to see the documentation of, somehow over the course of time, even putting the whole agency budget has phased out of what was being asked for, and so the context wasn't even there in the proposals anymore. And so again, looking overall at what the best thing is for us, and people are passionate about all the different sources, but it sounds like you have a number of sources coming in. You must have one big grant.
The Kansas Department of Health and Environment, yes, ma'am.
And how much is that one?
This year, well,
More or less.
this year it's about 300.
Okay.
And that, we have 300 for case management and then 100,000 for prevention.
Okay. And that's
Chair.
KDHE money again?
Yes.
Well, okay.
Chair,
Yes, ma'am.
I just lost connectivity for like 30 seconds and I did not hear those last figures. Sorry, I just got back on.
You want to read?
So our KDHE grant is about 300,000 for case management.
And then there's the second one.
And then the prevention is 100.
Okay, thank you.
Okay, I think we're done.
Okay,
Thank you
thank
so
you.
much. And I would call up healthcare access.
Last time we had talked about some outcomes, and so this is just
Thank you.
what we had just submitted here for our quarterly report. Some outcomes.
And if both of you, I think you offered, and did you by any chance submit to Liz in advance so this could go out to our?
No, I am so sorry.
Okay.
I did not realize that that was an option.
Well, if we
so-
can promise everyone that
Yes.
that will happen shortly afterward, we can send it on to those who are virtual. Sorry about that. Okay.
Yes, so I'm Megan Skaggs with Shawnee County Medical Society Health Access. And so at Health Access, what we do is we coordinate donated physician and primary care, specialty care services, et cetera, to uninsured, low-income residents of Shawnee County. We, on average, serve about 1,500 patients a month who are enrolled in the program. We enroll them for 6 months at a time. They have to be within 150% of the federal poverty guidelines. They have to have an identified primary care provider, and the point of establishing them with a primary care provider is giving them a primary care home. And our ultimate goal is to keep these patients out of the emergency room. And so we do this in a number of ways. Number one, we establish them at that primary care. That primary care will meet with them, see what other services they might need. We work with surgeons in and out of Stormont Vale Hospital. We work a little also with University of Kansas St. Francis campus. And We enroll the specialists of different varieties and specialties that we need ongoing. We have patients do physical therapy. We help patients in whatever way they might need. The purposes of the City of Topeka grant, your funding goes directly to provide these patients their prescription medications. On average, every quarter, we fill about 6,000 medications per quarter for these patients. These prescriptions, the requirement there is that they are generic and they have to be under $200 a month. So your dollars are going many ways. But we try to spread that as much as we can. They do have a $7.50 copay that they pay for these prescriptions. And as far as outcomes go, our grant goal is to have these patients report that they are not going to the ER. Our goal is to have 75% of them say that in the last 6 months when we re-enroll them and survey them, that they have been out of the emergency room. And the last year of our grant, at least 90% of them have said that they have stayed out of the ER. So our outcomes are very good. We are keeping these patients out of the ER. We are establishing them in their primary care home. And we are providing a very high need for them. I have been at Health Access now for about 7, maybe 8 weeks. When I came on, we did have a dip in enrollees, which I think is attributed to COVID-19. We had to redo the way that we meet with patients because we always had met with our patients one-on-one. We have an office at Grace Med over on Huntoon, and we had met with them as we enrolled them. We also enroll patients straight out of the emergency room if they do go, or we also work with the case management teams at both hospitals to enroll any patients that are inpatient as well. We do that on an emergency basis, and so we kind of drop everything when we get an application of that sort and get those patients enrolled, so that way they can get their prescriptions immediately when they discharge. In the 6 to 7 weeks that I have been at Health Access, we have enrolled a number of patients. Just in this last week, I have personally enrolled 25 emergency applications, and those applications are the ones that come in straight out of the ER or straight out of inpatient case management. And so without access to these prescriptions, which is where your dollars are funding, these patients would not be able to get healthy. They might get discharged but not be able to fulfill a medication that costs $200-300, however much you want a month, because they don't have that primary care provider, because the ones that we work with, they know that we have that $200 a month limit. And so they're making sure that they're prescribing those right medications. Sometimes if there is a medication that prescribed that is over $200 a month, what we do is we work with them, really their primary care providers work with them to get them on the the manufacturer programs to have those access to those medications. And so we work with case managers, we work with social workers, we work with a number of referral clerks in and out of these primary care homes that we establish these. We work really closely with Grace Med, really closely with case management teams. And the ultimate goal is to get these patients healthy, keep them out of the ER. We know that the top 5% of the population who is the sickest typically consumes 50% of healthcare costs. And the Health Access program is able to take these patients who don't have access to healthcare because they're uninsured, they're low income, they don't have the means to get healthcare. We're enrolling them in this program, and we're trying to alleviate that healthcare cost that is directly attributed to not having health insurance. Questions?
You did a good job of rolling that out. I'm still writing.
Thank you.
Yes.
Thank you. Yeah, that was really quick. Okay. I do have some questions. So you say you service about 1,500 a month, 1,500 folks?
Mm-hmm.
Okay. If you could just give me a yes or no. I'm having a hard time hearing you.
Oh, okay, sorry. Yes, sorry.
Okay, thank you. Okay, and do you see that 1,500 as pretty much of a rotation of folks, or are you dealing with the same folks over and over?
It's a mix. It's definitely a mix. We do have some patients that we enroll folks 6 months at a time. And so we do send out re-enrollment paperwork a month before their enrollment ends, and they can re-enroll. So what we do is we require proof of income again, and so that way we know that they haven't got a job and are out of that poverty income level. And so these are the folks who are the, very truly every 6 months uninsured at that federal poverty income level. We do have a number of patients that will come into the program, and then we're part of the LINK program as well. So in LINK, this is a program that's funded by the Topeka Community Foundation, and through the LINK program, what we do is any patient that comes in through the ER or through case management, we refer them to LINK. And then we have a LINK social worker that will go through a number of questions with that patient and identify them as high risk demographic for maybe they're food insecure, they don't have stable housing, they don't have a number of these things, and then we refer them over. Once they're established in LINK, we have a case manager that will further the work that they do with these patients, work to get them housing. Sometimes we will be able to get them on Medicaid. Sometimes we will be able to find a way to get them health insurance of other means. And then once they get health insurance, then they are disenrolled from health access, as with any patient. So we do actually, we work, I can't tell you how many calls I take a day with the billing agencies that will say, hey, I need to confirm enrollment. And because we have such a close relationship with the billing offices, if they see a health access patient and know that that patient is receiving health care of other means, they will call us up and let us know, hey, this person just got on Medicaid, or hey, this person just got Blue Cross Blue Shield, or what have you. And that way we know that the patients who are in the program are the ones that truly need it.
Okay, and with getting them on Medicaid, do all of your case managers work on that with trying to get them on Medicaid, or do you have one that's specific towards that? And what is your success rate with getting them into the Medicaid system?
Well, that is only done with patients who come through the ER and patients who come through inpatient case management. So it's only a number of patients that we refer over to this LINK program, because we work with Stormont Vale, Washburn School of Nursing, Vallejo Behavioral Health, and so it's a partnership of all of these agencies, and they have to, before we can quote unquote start working with them, they have to meet that requirement of coming in through the emergency room or inpatient case management, and then they have to have further questions of, and I apologize, I'm not intricately familiar yet, because I've only been here 7 to 8 weeks now, but they also have to meet guidelines as being food insecure. Perhaps they're homeless, perhaps they're this. So there has to be certain things that are met before we start working with them. I think it's been about 2 years that we've been working with patients in this LINK program. And I will tell you, these patients are very time intensive. They are very, very hands-on types of patients that we were working with. So we're not focusing necessarily on quantity of patients in the LINK program, more of quality of outcomes. And so I would say the last numbers that I had seen, overall, we've had about 90 referrals from health access to the LINK case manager, who's going to start working with them. And I would say, I think of that, the last numbers that we really looked like, we had about 35 what we would call successful closed. And that is the numbers that we would have: Medicaid, a job with health insurance, those types of things.
Okay, thank you. And you say that there's a $7.50 copayment that they pay for each prescription, with the maximum up to, you all provide, what is the $200
It's
limit you're referring to?
$200 a month per prescription. So if the prescription is over $200, it's not something that we're going to cover. So it has to be generic, it has to be under $200 a month. And then we provide a maximum of $1,000 per patient per year. And we very rarely have patients hit that $1,000 max per year.
Okay, thank you.
Yes.
Thanks, Chair.
Thank you. Question?
Thank you, Chair. Just as in the previous presentation, there was a breakdown of clients. Clients is all
Yes.
encompassing. Do you have an idea of the breakdown of male, female, ethnicity? And then I have a quick, does this include children as well?
We do have, and I apologize, I only grabbed my patient age mix data, so I didn't print out that page that had our demographics, and I'm not familiar enough with looking at that on the day that I probably cannot pull that off the top of my head, but I absolutely could follow up with an email and send you that. As far as our age demographics, we have 62% of our age demographics are going to fall between the 36 and 50, the age of 36 to 59 age range. We do have about, let's see, 40 to 50 patients who are pediatric, so under the age of 18. So we do have a number of, actually, we had one of these patients just last week, and this is one of the things that I do. We had a patient needed a pediatric cardiologist, and we did not have a pediatric cardiologist enrolled as a provider in health access. And so I was able to call up that cardiologist and say, hey, we have this need. Would you not only donate your care to this patient, but would you donate it to patients as they come across that we need it? And he said, yes, absolutely. Got him enrolled in the program, and now this patient got the care that they need. And so those are the types of things that I do as the director. When there's a need, we figure out a way to make it happen. And very thankful that we now have a pediatric cardiologist in Topeka, and he's willing to donate his time to these patients. We'd also do then have the next bulk of our patients is probably going to be between 20 and 35, and that's about 300 or so. So that bulk is that, working class. Some of them are going to be parents, single parents, where their kids are able to have Medicaid or can care, but they are not because they're not eligible for those types of programs. And so we have a number of single parents that we enroll quite often.
So their kids might be in the Can Care program, but they have nothing, and so you've got
Correct.
the parents.
Correct. Mhm.
So. Councilman, other questions?
Thank you.
All right. Similar to the questions earlier, could you talk about your staffing?
I am the executive director. I do a little bit of everything. And then I have 2 part-time staff. We have a department assistant. She's bilingual, and so she works primarily with our patients who are Spanish-speaking only. And then we have an enrollment specialist, and she also works part-time. And so we are a very small but very mighty staff. Our case manager, our social worker in the LINK program is actually employed by Stormont Vale. And so she's not part of our staff, but we do work with her when we work with those patients who refer to LINK.
And could you talk about where your funding comes from?
Yes, we have the grant that we receive here that goes towards those prescription costs. We also receive a grant from the county. So our total prescriptions cost every year is about $150,000 to $160,000, which is funded by the city, our city and county grants. We also receive funding from the United Way, Topeka Community Foundation, from Grace Med. We have an annual fundraiser that we utilize. Those are our biggest income as far as funder sources. I am hopeful that as we grow, and I do anticipate, looking back historically, when we're talking about 2008, 2009, 2010, when unemployment was at its highest, we were at our highest enrollees. We had about 2,500 patients that we had a month enrolled in health access. I would not be surprised if we're going to start seeing some of those numbers in the next 6 to 12 months, solely because of where the economy and what the outlook as far as jobs and employment is going with the pandemic. That's a big concern for me, especially as we see, funding sources get harder, funding reduced. What do we do with these additional patients that need prescriptions, that need things, that need this, that need that? We're very lucky with the providers that we have in Shawnee County. Just this week, I was able to bring on 28 new physicians, and so I'm in the process of enrolling them as volunteers in our program. And so that need is being met. But the prescription cost is a need that will also go up as we enroll more patients.
And I've asked this before, I think years ago, sometimes our volunteers are our best donors.
Absolutely.
But you all have chosen not to ask your hundreds of physicians.
Well, we have our annual fundraiser, and our fundraiser, we call it Music, Just What the Doctor Ordered.
Right.
And our physicians are putting on our
Right.
show for us. And so that brings in, last year, our goal was to bring in 20,000 from that fundraiser. Unfortunately, because of COVID-19, we did have to cancel. We still did receive a number of donations that we got anyway, even though we had to cancel it. And I think it's really important to keep in mind that when providers are seeing our patients, they are not meeting their RVU income. Physicians are partly paid on what they call an RVU basis. So it is a production basis that you might say. And when they're donating their time to our patients, they're not getting paid. They're not being, that time is not being counted for them. So it's time from their provider, but it's also goals and financial metrics that they are going to miss by being enrolled in our program. So they might not be writing a check every month. They write a check once a year for us, which we're very, very grateful for. And then they're also providing a lot of their time, especially these surgeons. The providers who donate these surgeries, that is a huge cost to them, and we're very, very thankful for that.
It's a phenomenal program. It just, these are the tough questions that you
It
ask
is.
when you're
Yep.
looking.
It
because
is.
It's often easier to raise money for stuff, if you will, than for services.
Yep,
It's just more satisfying somehow
absolutely.
to people, and so just checking.
Yeah.
Thank you so much. Other questions, the committee? All right, thank you again.
Thank you.
And you sound like after 7 or 8 weeks or whatever it's been, you've got it nailed. They did a good job.
It's such a great program. It's very exciting to dive into it and learn all that I can. And serving the underserved is a great passion of mine. And so I'm very, very thankful for this opportunity with Health Access. Thank you.
Thank you. All right. Seems like we need a break. This is pretty intense here. Thank you again. All right, back to our review of process then. Last time we talked about outsourcing. We did not make a decision, but we had very positive feedback and no negative feedback. My inclination is maybe we just want to carry through these open issues because some of them relate to one another. But I just wanted to quickly review I had a question for you, Corey, staff. When does that contract actually renew?
It's a wonderful question, and I don't have the contract with me. Maybe United Way knows the answer to that.
Brett Martin, do you know, or, it's a new contract, so we started in the fall.
Yeah, I'm thinking it's about renewable about this time. That's what I'm thinking.
About right now?
Yeah.
Okay.
Yeah.
Just checking, just to refresh, it's kind of a two-part engagement. There's the application processing in part of the engagement, and then there is the grant management. So we're in the first active part of this first contract, moving into the second.
Chair,
Yes.
I wonder too, when I was reviewing the minutes, I had brought up, and I think we were gonna discuss it, the 21,000 cost for outsourcing to the United Way. That was not taken off of the top of the grant funding this first cycle. So if we go in for this to renew, the 21,000 that will be paid to the United Way where will that be coming from? Because I know that there was some discussion about and not being sure.
The
I
minutes
just
that
hope
we
it's
were,
not being taken off the top of the total amount for grants.
so when we vote on that, you think that should be included in the recommendation to the body?
Well, I just wanted to know where the fee was gonna be coming out of.
Do you want to have, do you have a
Sure.
response for that now?
Yeah, I've been assured that either we will be using our CDBG funds, or the city manager will find some funds in the general fund budget, so it will not affect the bottom dollar on the agencies.
Okay, thank you, Corey. Thank you, Chair.
Okay, thank you. The 2022 calendar was the next item that we had covered, and staff had provided us a proposed 2022 calendar. I got to thinking, we asked about whether it had always been what was proposed was let me find the right packet here, was basically an April to July routine. But even last year, it was supposed to be a February to May routine, and it got bumped just because of COVID and the things that were happening. So aside from the year before, it's always been it's for some time it's been a February to May routine, which did not come up last time, and so, or wasn't affirmed. And so I wanted to make sure, I reached out to Brett and Jessica at United Way only yesterday, having reviewed and determined that. I don't know that it has to be finalized today, but Brett, did you have any thoughts immediately? We never really talked about what United Way's rhythm is, assuming we would continue to contract, and whether there's a better window in your time of year for that, be it February to May, March to June, or April to July.
Yeah, thank you, Chair. We were in the midst of Christmas Bureau intake yesterday, and so I was not able to meet with my team to talk through that. That's
Okay.
a conversation that we could have. We've had some changes in our cycle as well, and have moved everything to a July-June calendar for both basic needs and impact contracts. And so that would be the case this year as well. And that process would really run kind of March, April, May for us. So there would be overlap for us. The question is, where's the best overlap? And I haven't been able to talk with Juliet and Joyce yet about seeing where that might be best.
Well, for the purposes of today's meeting, is there anyone from our staff or from the committee or from the agencies? I wasn't sure it mattered to anybody, but if it does matter, if there's a reason, and we still have the delay and that goal of the city's budget affirming it. The reason it used to be February to May was so that the allocations process was over before the city's budget was even recommended to the council, so that it had been, whatever that preliminary number, the approved number before, had been affirmed. So it pushed it way into the process this year. Again, if there's, I'm not pushing for any issues, but if anybody sees any reason why that would be a problem, if they think about it right now, please speak up, or let us know if you think about it later. I'm looking on the screen and around the room, not seeing any comments. So we just want to put it out there that there might be some options of swing. I'm not sure it could swing any farther than that. This committee kicked in right away when we got appointed in February because the process was changing and we really wanted to work with United Way. So that's something to keep in mind. but even that March, even a February announcement date, that's enough time to have a briefing for a new committee and get them ready for the process once it's not in flux, it seemed. Okay, well, we'll decide that too in time. The next item that we had discussed last time was the issue of the minimum grant amount. There'd been some disconnect between what the application form said and what actually happened at the end. And United Way had been new to it, so they didn't realize that when the recommendations were made. Further thought on that issue, whether it should be that the minimum application is for 10,000 and then we see how it works out, or keep the minimum grant at 10,000. This could be, when we get to how the scoring and recommendations are done, it could resolve itself out, I should say. The reason that those grants have come in under 10 is because the system that was being used by the city was an absolute percentage scoring system, and it was not negotiable. So that's how the numbers went. Any further discussion on that issue at this juncture? Further thought?
Chair, I'm with the, keeping it at the 10,000,
Yes.
just keeping it at that. And like what you're saying, where we had some that went below that amount,
Correct.
right? Yeah,
And you're inclined to
I mean-
keep it, the grants themselves at no less than 10?
yeah.
All right, yeah, okay. Well, let's stub that in for now, because we'll see when we talk about the scoring and recommendations. Any more thoughts on your part, Councilman?
No.
Okay. Excuse me. Then the priorities page, we did have the not grandfathering, whatever it is, the carryover higher application amounts on that sheet. We could call it the caps for agencies, whatever. You do have a marked up copy that reflects the discussions that we had so far. Those changes from prior included the outcome, using outcomes-based in that mission statement line. Dropping the wording of grandfathering, but we still need to decide about whether we would carry those over. And the tentative agreement out of last time was to simply drop the category of new untested programs and instead just require that any agency we would fund would have had that, any program that we would fund would have had to have been in operation at least 2 years prior, whether it was funded by the city or somebody else, 2 years prior history before the application occurred. And that otherwise we'd no longer have 2 levels of grants. Any reconsideration or further thoughts on that? If not, we will get to what's at the bottom of that page when we talk about how to do the allocations.
Chair,
Yes, ma'am.
let's go over that one more time because I had some problems opening up my document,
Okay.
and I'm looking at the 2 agencies. Are we looking at the 2 agencies with maximum grant amounts at 50 and then Positive Connect, or Shawnee Medical Society at 50 and Positive Connections maximum at 35? So what we're talking about is whether we want to keep that in place or to change it and or to do away with it.
Correct, and we can talk about that now if you like.
Um, I'm just going from your lead on this.
Okay.
Not having all the hard copies, I'm pulling stuff up and down, so I apologize if I'm moving a bit sluggish on this. I'm open to discussing it.
Okay, do you have a recommendation?
You know, my concern is, like I said, I understand that the 35,000 for Positive Connection is going towards a case manager. I mean, I think it's fine to articulate, you know, other concerns I may have. I believe that what they're doing is important and vital. However, I do have some concerns that they appear a bit top heavy on staff, and those are just my thoughts. I think it is important to keep these agencies at capped amounts, provided that they go through the application process every year. I think that there should be some dialogue with Positive Connections on what that amount should be, because I believe it should be 25. With the increasing need that most likely we are going to be seeing, I agree with the amount of unemployed, uninsured because of COVID. And the very little staff that Shawnee Medical Society is working with, you know, hopefully they'll be able to up that staff a bit. I think that we should keep them capped at 50. I do believe it's important to keep them in the program, provided they provide, you know, the thorough application process and metrics that are needed.
Councilman?
Okay, thank you, Chair. You know, again, I think oftentimes for me, what goes to helping me decide where I want to be on an issue, it helps when I get, like I say, a field trip and go and see them in their workplace and see what they do. I've done that with Health Access as well, with your predecessor. And so felt very comfortable with what they were doing, and pleased that this community has that in place to help the underserved in an area that oftentimes people really struggle with meeting the basic needs of healthcare. And so I'm fully supportive of keeping them as an ongoing, if not grandfathered or whatever you want to call it, program at 50,000. And I did the same thing with Positive Connections. And for me personally, I think I was surprised at the amount of services that Positive Connections provides, again, for a community that may or may not be a priority for healthcare. I mean, everybody looks at the things that you see all your commercials on and everything else, and now you're seeing more about HIV, and I think that made me feel good about what this community has in place for that population, so that we are able to provide some real necessary services. And again, in both organizations, they're serving a population that struggles with access. And for me, I think that's important. I mean, having it there is one thing. Having access and having someone there who will one-on-one talk to you about what your needs are and how you will get into a system that will help you with those needs and keep you in that system, so you don't fall out of it and come back and have to try and keep making appointments to make up for what you missed on, or your conditions got worse, And then that's another thing that yeah, increases the cost for everybody and the pressure on staff to provide those services. And I think, I'm very comfortable with the fact that the explanation that our grant doesn't cover food costs or anything else, and they've been very active in finding other grant sources to provide for the other resources that they utilize. And I'm very comfortable at the amount of $35,000 to stay in place for a case manager for the positive connections. And
Okay.
that would be my counter.
Well, I will throw in mind that notwithstanding, I am really impressed with both agencies, but I am equally impressed with all the other agencies that we fund and the challenges that they all take on and the reach out to the particular clientele that they serve. And so I'm I'm supportive of all of them, but I'm not sure that any have a particular reason to be granted more money than another. And I also think that we've got a community that can come forward and can support as well. And so I support the agencies, but if we're gonna pull the minimum grant up, for instance, to 10,000, that would cut off one or two agencies that we're funding right now if we had already. And we have not raised the amount of money that we have recommended to the council in some time, which means that already the $25,000 cap that we have isn't allowing, inflationary growth on what we have contributed to the other agencies, to any of the agencies all along. We may discuss a different way of making the decisions on how much the allocation recommendations are here before we get done today, but I think the pitch could be made for each one of our agencies that they are worthy of whatever X amount of money is. And so I'm inclined to drop the grandfathering and then look at what our minimum and maximum would be overall for all of the agencies that we fund, without any judgment about worthiness. That's not it for me. So we don't have to decide it right now, but we needed to have that conversation and just get that out on the table.
So when would that come, Chair, when would that come up for a vote?
Well, we have all these various criteria that we need to address. If you all want to, we haven't voted on any of them, but we've discussed them and gotten the pros and cons out on the table. So unless you want to do that now, we've been sort of stubbing in where there was consensus. It doesn't sound like we have consensus on this one at this point. We might by the time we get done. I don't know.
Yeah, it was just a question.
Yeah. I would suggest that we move on at this point and get back to the conversation which United Way is really prepared to lead for us, to talk about outcomes and process and application questions and scoring. So if that's okay with you, I think they're all interrelated, so I don't know that we need to go through them one at a time unless unless you want to, Brett. But I would hand off the floor to you.
Thank you, Chair. Let me make sure that I'm following correctly. So I have some notes that that came from both the city and the committee based on some discussion that we had in our last meeting, and then wanting to talk about those this meeting. So I have those prepared. I also have some conversations and some pieces related to issues that we came upon during the process that were either shared with us related from applicants or that we found in our pieces. And so when I take a look at those in some ways are technical questions related to the software. Some of those are related to process. And so for the purposes of today, I can share those with the committee and we can have some high-level conversations related to some of these technical pieces that then if we want to share with city staff, we can, and then we can talk maybe a little more about process if that's agreeable to you.
I think I followed that. So do you want to just raise what the issues were on technical and refer them to staff and move on to process?
Yeah,
okay.
I think so.
Let's do that.
And this is a document that after we received those talking points, we were able to put together yesterday. So I've not sent out, but I will following this meeting, and we can take a look at. Some of these are related to the application itself. And I think as grantors in particular work in software, and as software programs like EC Impact make updates, sometimes it's important to go back and take a look at the application and see where it is that the vendor has made improvements in the software program so that then some of these pieces are easier for applicants in particular. And so the current form in there happens to have a drop-down menu. And when we took a look at that drop-down menu, and we worked with agencies, only about half the agencies completed it correctly because it was confusing in terms of the wording. The drop down for it says application, program type, and program category. Probably just needs to remove those fields and put in some language that more mirrors what's in the RFP, so that the applicants have a consistent language moving from the request for proposal through the application and so forth.
Okay.
The 7850 resolution, that there was some confusion from the agencies in terms of what they needed to provide there, and it would probably be a good idea to build into that process a sample of that required document and then some steps to be able to acquire that, which I think would be a fairly easy fix.
I'm not sure what you're talking about.
75.
A 78?
Joyce, you want to talk a little bit on that?
7580. It's the 7580 that says you don't owe the city any money ordinance.
Oh.
Yeah. It's an attachment. Yes.
Okay. For people who couldn't hear, the 7580 is a form that gets attached that shows that you don't owe the city any money. We're blissfully unaware of that, or at least I am, so, okay.
Never heard of it.
7580, thank you. I transposed those two. Thank you, Corey.
That's all right.
And so I think that would be a fairly easy fix. And again, always a good idea if you're asking for money from someone to make sure you don't owe them. So
There you
certainly
go.
want to keep that as part of the process. Certainly had to do that with my parents growing up. There are, within the application, there are two different areas where this particular grant revenue is reported. And rather than having two of those areas, just combining them. So there's one line for the city general fund and one for CDBG, and maybe just having them report that all in one line so that they don't have to break that out. So there's another question in terms of the application related to whether or not prior grant partners with the city have turned in their reports in a timely manner and have successfully managed the program. We found it a little clunky on our end to be able to inform our reviewers about that. Rochelle did a great job getting that information to us, but I think as we take a look at that application and the review piece, we should probably have some conversation about how to make that a little more streamlined, either adapting that question in the score sheet or having maybe more training with the reviewers so that the reviewers understand exactly what that question is asking so that they are able to score it accordingly.
Well, and just to clarify on that one, now that we're outsourcing, and then we are also talking about bringing agencies in for the first time that would be scored, but their history is elsewhere. Really, as a third-party vendor, you have to check with us just like you'd have to check with whoever their other grant providers had been, so it's about the same instead of a hurdle like it seemed before?
Yes, yes.
Okay.
I think so. And so I think just some clarity related to that as we move forward for whatever this looks like, I think will be helpful.
Okay, got it.
There is a new feature within EC Impact that allows for a blind review from the reviewers. So typically a reviewer, when she or he is reviewing the application, they are able to see the agency name. There is now capability for a blind review. Obviously, if a reviewer has been around a long time, they'll likely be able to figure out who that agency is just based on their services. But it could potentially be a better way to move forward, potentially making it sort of a more robust and actually transparent process by having a blind review. So that's certainly something for us to undertake. And again, that's a software improvement from EC Impact that has not been there previously. Also, then some conversation about cost per unit. Cost per unit on the application is not currently asked. Cost per unit is tricky. It's incredibly tricky from a grantor's perspective and from an agency perspective. We recognize that among the various service agencies across our community, cost per unit can look different for any number of different reasons. And so, a cost per unit isn't a cost per unit isn't a cost per unit. But to be able to have something in there for reviewers to take a look at, I think is important, but I'm not exactly sure what that looks like. But there is no way currently for a reviewer to give any sense or to have any sense of cost per unit. And I think if they're looking at program of effectiveness and potentially return on investment, that may be something that they would find valuable.
Is that something that EC Impact can simply calculate? Is that a capacity? And this is just a question, but if I've told you what my budget is and I've told you how many clients I have in an oversimplified term, you could calculate it. On the other hand, as we were discussing earlier, if it's a caseload per case manager comparison instead, that's more important, or how much we're spending overall per client that might need to be done by the applicant, just so that it's with some instructions. For instance, if in the example that we had, I'm just thinking out loud here of positive connections, where you've got a case manager, but plus you've got an average amount of goods and services that are provided additionally to each client. Different in the cash support to them or cash and goods than just the cost for the case management. That's kind of where you were talking about it being tricky, just as an example.
Yes. Yes,
Okay.
because again, you know, if a cost per unit isn't a cost per unit isn't a cost per unit, a unit isn't a unit isn't a unit.
Right.
And that then makes it incredibly difficult as well. When we heard from our senior centers, for example, a couple of weeks ago, and they were talking about, rightfully so, that in many of our agencies, the staff is the program.
Mm-hmm.
And so that if that is the case, then what is your actual unit when you're dealing with people? And you could very well see, for example, that an agency, if they end up getting knocked down in one application for a cost per unit, could easily then shift that cost per unit to help themselves out the next time, because it can get tricky, right? So is a unit a person? Is a unit a contact? Is a unit a provision of support? Because you could, for example, have one program that serves 60 people, and they could say their units are those people that they serve, and they would be at 60. Another peer organization might serve 65 or 45, but their cost per unit, or their unit, excuse me, is not defined as a person, it's defined as a contact. So they might have 1,000 contacts. So then their cost per unit would adjust there as well. And so I think as we think about cost per unit, it can get tricky. Units can get tricky, cost can get tricky, but I think it's important for us to at least have some conversation about what that might look like moving forward, because when it gets down to brass tacks sometimes and people have to make hard decisions, you look at cost per unit. You don't only look at cost per unit, which is why it's only potentially one part of a rubric, but it should be part of a conversation.
Well, and you also have what often is called direct and indirect. In other words, the cost per unit, cost per client, or cost per unit of service is very different, where we talked about just, and I'm being random just for an example, but the senior centers where the executive director is the program and so on, versus an organization that's got case managers and supervisors and assistant clerks or whatever, where somehow those costs have to be included in the cost per client or the cost per unit of service as well. So because it's part of what we're spending or we're contributing money to do.
No, and you are absolutely right, and gets down to some of the difficulty of some of our programs. And when I say our, I mean within the city of Topeka. You may have that one director who is the program, and they might get knocked down in any number of different conversations because they're too lean. You should have more people doing that work. Well, okay, we don't have the revenue to be able to do that. But then at the same time, you would have some people who would look and say, actually, they have too many staff. They need to lean up. And so a lot of that is difficult, and it's the hard work of grant making, and it's the hard work of grant reviewing, and it's the hard work of working together in a larger system. But I think at least having some conversations about cost per unit and definitions of unit are something that we should be able to take a look at, so that reviewers have the best possible information to make the best possible decisions.
Thank you for that, and we'll be moving on through this discussion, but is that something that you, in the whatever you're using right now for United Way or other models that you've worked with, that you've seen addressed in a pretty empirical way successfully, or is that something that in your experience needs to, at the end of the day, be part of a more subjective, analytical conversation?
Maybe. So sometimes I do a good job of standing up and speaking in such a way that I've got it figured out. This is not one of those moments. We have not figured out cost per unit. We have not figured out units.
Okay.
It is a very tricky situation. I would think this is a conversation that would we would all benefit by having programs and agencies contribute to. Sometimes we find in bringing in partners that they have worked with other grantors who have figured that out, or they're part of national organizations that have figured some of that out, or they have some best practices through accreditation agencies that have helped them with that. And so I think that would only improve if we folded in some program partners to have some conversation about that.
Eric?
I can't see, but it sounds like Councilwoman Valdivia Alcala wants to speak.
Yes, thank
Okay.
you, Chair. So Brett, when we talked last time about getting all the funding organizations together, which I think is a wonderful idea, is that in the realm where we could have this conversation?
Absolutely.
Okay.
Absolutely.
Yeah, then I definitely would be open to that. Thank you, Brett.
Thank you for that comment, because we did come up with the discussion last time about getting the funding agencies together, but I've been through, as a nonprofit exec, all kinds of applications and all kinds of decision-making processes, but that cost per unit, one way or another, or at least the budget analysis and comparison, is something we've been missing in our system, and it is important. So it's good. Keep going.
Related then to some other pieces, just in terms of the notes that we received, I just wanted to follow up with the committee to let them know that I followed up with Ms. Lake at Pappin's Landing and was able to provide information there and follow up. We had good conversation moving back and forth, and the clarification related to the score on one particular part of the application. And so I wanted to let you know that we were able to resolve this. The other piece that is probably significant here is this idea of standard outcomes. And this is, I think, Councilwoman Valdivia Alcala, this is what you were referring to as this larger meeting of our programs, to be able to take a look at standard outcomes and to potentially put some of those forward so that we have a better sense of what we are measuring across the community. As I mentioned, there is no part of the rubric that requires the reviewers to give any score related to the quality of an outcome. And so a program can put forward outcomes, but the reviewer does not have space within the current rubric to score that as a strong outcome, a moderate outcome, or a weak outcome. And I think in this conversation about outcomes, it would benefit all of us if there were some sort of summit of programs to come forward to talk about outcomes, to talk about logic models, to talk about leading indicators and lagging indicators, so that insofar as we're able and have it recorded, everyone has access to the same amount of information, so that our applicants have a more level playing field. Some of them, for example, may be part of organizations nationally that do a really great job with this, and they do it as part of their continuing education or something like that. Others may not have that, but at least we could have something locally that would be able to collect, would be able to collect our groups together and provide them with that information.
I have a question
Related.
on
Sure.
that, if I may. And you brought that up last time, but that's an area that we thought, when it was created, was pretty well done. That it required that you define the need that you were addressing, and that is scored. And then you define the outcomes that you were proposing related to the need that you, the agency, defined, and that is scored. And then there's another section on outputs as different from outcomes, which of course tests whether you know the difference, and gets scored as well. So, and then you get some points for having a clear plan on how you're going to measure those outputs and outcomes. So what is the failing in that setup then? Just not tying them to master objectives of our own? Or if you could help with that.
Yeah, I think so. I think twofold. First, I wouldn't think that there's a failure in any of it. I would say that there's opportunity for improvement and
Okay.
opportunity to move to another level in the community where we can take a community level view so that, for example, this committee can go to the council and then go to the taxpaying citizens of Topeka, and to be able to say, this is what your dollars are doing by looking at more of a master set of outcomes. I would also say that while a program is certainly required to define a need and then to be able to describe the activities they're going to carry out in order to meet that need, the outcomes that they have defined, their outputs. There is still a way for, I think, us as a committee, as you all as a committee, to be able to raise the bar there for programs. So this is going to be spitballing, but I can give you an example of what this might look like. Okay, so let's say I have some data, some LMI data related to an area that I serve. So I have census data on income. I know that there's no grocery store, so it's in a food desert. I have a program where I say, I want to feed kids. I want to feed kids because I know that there's a low income area and that we're in a food desert. And so I want to serve bananas and peanut butter to kids. That's my activity. Okay, and so I know how many kids roughly are in this area based on this. So I put that data out there and I say, so I want to distribute bananas and peanut butter to this many kids in this way, and then these are my outcomes, right? So I'm going to meet, I'm going to serve this many kids in this way in terms of this percentage of the population with the peanut butter and the bananas. And I'm also going to do a survey and ask the kids how they like the peanut butter and the bananas. And I want that rate, my outcome there is going to be a 75% satisfaction rate. I can put that out there, and I've actually met all of the requirements of that. I've met the outputs, the activities, the outcomes, I've defined the need, all of that. You may want to invest in a program like that, but I think there's a way to raise the bar for programs to think about more than just serving peanut butter and bananas, and more than just a survey, and more than just satisfaction in that way, to actually start getting to hard impact. And I think if we're starting to look at things like master outcomes, we can help actually raise our programs up. And many of them, as I've said before, are doing things, but nobody's asking them. And so we don't get the answer about what they're doing because we don't ask it. And many of them would say, well, we may be doing things like this, but we've never been asked this type of outcome question before, but we can certainly start measuring it, and we know it anecdotally or something like that. So it's not to say that all programs aren't there, but I think it's an opportunity for us to help raise all ships by sort of raising the expectations related to, say, a master set of outcomes or something like that, that helps programs, that ultimately helps clients they serve, but then also helps to report to the stakeholders, that is you, city council, city manager, citizens of Topeka, in terms of being accountable for the dollars.
Question.
Yes.
Chair, question on that for Brett. So is it, would this be a way for these master outcomes and then looking at formulating these funding meetings with these large funders? Isn't it also a way to really get a handle where we may see duplication of services? Also, where we may be able to drill down enough to really look at the hard, like at the root of these issues by drilling down into all of this information, rather than, I'm not saying we're just throwing money at something, that's not what I'm saying, but just getting that more in-depth and more collaboration to where the dollars are spent more wisely, that we can report that then to the taxpayers, especially as we go into the coming times, because I think we're going to see more financial hardships just nationally, and I would say that locally and statewide as well.
So, thank you for that, and this drives back.
But I was asking him if that's what he thought. I mean,
Okay.
if that was some of the behind the
Yes.
scenes thought.
Yes, I am thinking. Chair, is it okay if I answer?
Please.
Yeah, so yes, I think that is part of what we're taking a look at. But, so anytime we talk about duplication, I always try to think of it from a program perspective and from an agency perspective. And I think sometimes when an agency or program hears duplication, they might think, oh, maybe I'm in jeopardy because somebody else is doing what I'm doing. So there's a flip side to duplication that I always want to talk about, and that is duplication. Yes, it leads to wiser investment and more strategic investment, but it also helps individual programs. So for example, if you partner and with existing agencies and programs within a community, instead of just starting another program within your agency, you're actually strengthening and leveraging the resources of both. So for example, and again, I don't know every partner inside and out, but not every partner needs a clinic on site. Not every partner needs a food pantry on site. Not every partner needs to do their own housing supports and rent utilities assistance. Not everyone needs to do that. Some do, but not everyone needs to do that. If we were able to work better together, we could make those dollars stretch. That's actually something that we've done in the Healthify pilot, for example. Community Action has the back office folks to do the work of sending all of the payments to utilities companies and landlords and banks. They have the staff to do that. So in our pilot, what we did is we put the money with Community Action, and everyone processed them on their end and then sent them to Community Action for payment, which means that little agency that is already stretched, they don't have to worry about writing those checks to utilities companies or to landlords. They used the resources within the community and a simple click of a button to be able to do that. That didn't minimize the work of that smaller agency at all. They're still incredibly valuable, but they're not duplicating that part that they didn't need to duplicate. So yes, I think there's opportunity to take a look at duplication of services in that way.
At the same time, then we talked about it with seniors, where having one mega senior center isn't necessarily a solution. If people do better in a smaller group that's a little more intimate, or one of the ones I bring up when those kinds of is daycare. You need multiple daycare centers, not just at a certain services. You need many of them, and others you need networked, and others can be a mega center, and that makes it challenging to review grants or to provide that guidance, especially without that big collaborative bird's eye view on everybody. So it's
I think, Chair, I think that especially when you're talking about seniors, I mean, that's kind of like a no-brain approach. If you talk about aging in place and understanding that seniors, need the places where they're familiar, obviously the mega, some kind of mega place is not anything that I would even ever suggest. But I understand that duplication of services isn't going to be fit into every single niche everywhere, but in some areas it will. And so I agree with Brett in that area. Senior centers, I think, definitely are the exception.
I agree. I just threw that out as there's this counterpoint to it, and it gets back to this process that we're looking at right now. How do you put that bird's eye view of how things could run smarter and better into your grant review process in a fair way, so that maybe it's not just this point system that we've had before that said, you tell us what your outcomes are, document the need that links to that, tell us your outputs, tell us what you're going to do, and bang, you get funded. Let's just say, and I'm not saying, I think our process has gone well, yet if there were observations, I remember in United Way hearings years ago when I was the executive director and presenting for an agency, and they would ask me these tough questions about, could we have networked with somebody else or whatever. It made you very uncomfortable, but they were very productive questions to ask in terms of making sure that we were working as on behalf of our clients in as networked a way as possible, and that the dollars were being used. And we have not had that element in our grant making process. Whether we need to or not, I guess is a juncture that we're at, especially if we're making core grants for important things that are between $10,000 and $25,000 or a little bit more. How specific do we need to be? Yes or no? Again, we can decide.
Are we able to talk?
Kathy Vota, is that you?
It is. Are we able to talk? Because I just had a suggestion.
Okay.
As a former grant reviewer over the years, if you're not familiar with an agency, then it's always helpful at some point on an application to be able to see the successes of that agency over the last year. What have they done with the money that has been given to them that has been successful, and how many people were served by whatever that agency has done? Because if you're walking in as a reviewer and you have a stack of grant applications that you're looking at and you're really not that familiar with certain agencies, only the rundown that you have received, to be able to see in a nutshell somewhere on that application that this agency used city money for this, and that program over this year was successful because of, it's still showing your outputs and your outcomes and everything, but it's also showing the taxpayer that that money is going to where it needs to go, because look what it's doing.
Thank you for that. Thank you. Let me get back to Brett here and see, we've had a little conversation, but you may have had some more points to cover, so.
Yes, thank you. Just a couple. As part of that conversation on outcomes too, I think it's important for us to potentially talk about, have something like a local data summit, to be able to bring in folks who work in data, to be able to help programs know where they can source local data related to their programs. So perhaps even some state agencies, our state agencies are sitting on a lot of data, and they use them for various reasons, but those are often disaggregated based on county and municipality that may be beneficial. There are also some different dashboards, and I think having folks be aware of those is important, particularly when they're going to define the need. Oftentimes we hear from applicants, it's really hard to find something local. You can find something at the state level, or national level, but to find local is tough. And so this may be a way for us to help. Again, it's training, empowering, and helping not only with city grant applications, but also other applications. Anything that strengthens any grant application by one of the programs in our community benefits us all. The last couple of pieces I think were addressed today related to the grant amounts the so-called grandfathering and the maximum amounts. Those were in some of the questions that we had last meeting. And then also for us to be able to take the score sheet that is provided and to align it with the application. So these reviewers put in a lot of hours reviewing the applications. It is much easier when the score sheet and the application are indexed, so that when they are looking at the score sheet, they know exactly where in the application that information can be found, and to be able to put those in an order that's easy for reviewers, I think is a process improvement that will help our reviewers for certain. We went in and worked on the hours for these reviewers that we had, and as I mentioned, we had 3, and their work totaled well over 100 hours being able to do this. And so if there's any way that we can make it easier on them by a simple alignment, I think would be helpful.
Wow. Okay, so those were more on the tech side, just the sync up using the system that we have today. We've got about 6 minutes left before our time slot that we had planned on expires today. Did you, in maybe just a thumbnail, have a thought about whether we should continue using and maybe a slightly tweaked version of the system we've been using for some years, or whether you had an alternative to offer to us to consider?
I think in the conversations that we have had internally with staff, that we feel like this is a good standard process, but like any process has opportunities for improvement. And just as we're doing improvements on ours internally at United Way and also sharing those with other folks, we have shared those with you as vendor here. So in terms of any kind of wholesale changes, we didn't discover any of those, other than, again, taking notes throughout the process, getting feedback from applicants, and providing that to you today.
Okay. I just wanted to, I haven't seen a United Way application form in a long time, so I don't know what the other ones look like these days, and I personally don't know what the process is. We learned a little bit anecdotally along the way that you all don't do hearings anymore either. You use the application form itself, ask questions if you need to, so I didn't know that anyway. And I didn't know if you would have suggestions about just a wholesale change, you know, using your process or your forms, for instance. But if you think we're in good position to continue using pretty much our process and our forms, then we can certainly take that under advisement as a committee. I just didn't want to go too far with our forms until you'd had a chance to suggest an alternative. If I can take just a moment and look to the agencies who are also online, does anybody else have a suggestion that we should wholesale make a change or stick with what we're doing, what we've been using pretty much? Okay. Appreciate that. Just wanted to offer it wide open first before we went farther. Brett, more thoughts?
I would just say one of the conversations that we have had is that all of the feedback that we can provide is only what our experience has been, and that has been through looking at the application, the score sheet, the RFP release, the applications, the scoring of the applications, and we are just into the contract piece. So in terms of the grant year and in terms of the process, we are in really just those early stages. because the grant year and the grant awards have not been made. And so we're just wanting to remind the committee and the agencies that our commentary and our comments can only be on the experiences that we've had so far. When we get to this time next year, we'll certainly have a lot more experience in terms of reporting and working with agencies and those types of things. But right now, this is really all of the pre-work. So, which I recognize is the foundation that really sets the process in motion. But just wanted to clarify that.
Well, it's sounding like to me from the conversations that we've had that that if what's generally working its way out of this conversation is that we should go with the system that we had before, that based on your conversations last time, that we might look at the very top line, the mission statement line of our priorities sheet, and if we're going to say outcomes based, perhaps revisit the language that we have there in terms of what our intention is to provide these grants. We've got the categories below, but we're really, if I'm following your feedback for us, we're stating the kinds of outcomes that we're looking for in that first line, and that we need to revisit that. We also, some of the technical things will be taken care of. Looks like the grant management scores, we need a system, but that just checking with whoever those prior funders will work out for you. And that we need to look a little more perhaps at that budgeting, what we're asking for in terms of agency and program budgeting and cost effectiveness in that. The one other note that I brought forward that we used to have in the application and then it apparently migrated out for a while, but Kathy Votaw has suggested that there be an overview. They'll let the agency just kind of tell its story a little bit. This is who we are and so on, to give a reviewer either a refresher or something, or an introduction to the agency. But also, because we found out that there were things going on that we didn't know about years ago, we for some time had a question in there about whether the agency was undergoing a strategic planning process, either because internally they had decided to review who they were and what they were going to do in future years, or because a primary funder had directed that they needed to consider such things, so that the reviewers were aware of it. I'm guessing that got migrated out because there weren't points associated with it, yet it was important to understand the agency. So perhaps without going through those things today, we could all keep those in mind to obviously come back and kind of then go point by point. Are there other scoring elements or points in the application form itself that people would suggest that we look at for future? Because we can, if we have those suggestions today, then we can all keep them in mind to come back with some commentary and make some decisions. Anybody at this point? All right. Oh, and there was a fix that needed to be done in terms of board representation. There was a disconnect between what the application form said and what the scoring form said that we need to fix as well, correct? Just trying to go back and gather up all those notes.
Yes.
Okay.
I would say just one more piece, Madam Chair, related to the strategic planning piece. If that were the desire of the grants committee to be able to do that, I would suggest that agencies have a year to be able to know about that before it's part of the application For example, if that were put on this year's RFP, that would then, for those who are not operating under a strategic plan and who didn't know that that was a qualifier, would then be pushed between August 20 or October 29th, that's today, is today the 29th? Yes, the 29th, October 29th, and application day to be able to put together a strategic planning committee within their organization and start working on a strategic plan. I would just suggest that maybe that is put out to the group, there's conversation, and then there's a year before organizations are scored on it.
That was
It's
not
just
a
a thought.
requirement. And I'll tell you the
Right.
context of it was that we had the senior centers were all applying for transportation money, and it was not disclosed that the JAAA at that point had put all of them under an order that by October of that year, they were supposed to be working out plans to collaborate on how they provided services. And at that point, we did do hearings, and that information came out in the course of the hearings. And again, with a strict point system, perhaps it didn't matter, except it really did compromise a little bit the issues of granting the money for those purposes, and it got worked through. If you could speak for a moment, though, about the scoring and how the application, how the recommendations for allocations, any thoughts, Brett, or that others had about that, that hard, just formulaic distribution of the money versus a more conversational and subjective approach. You touched on that before.
Yes, thank you. Within our United Way process, within the panel process, the scores are one part of a conversation, and they are part of really 4 tools that are used by the reviewers. The first is their individual scoring, which they do separately. The second would be the program review that they come in and they do in person or by Zoom, as it were. And they go through and they provide unique positives and unique concerns for each application until those unique ones are exhausted. At that point, then they take a look at their scores of those organizations, and they look at the and again, we have more than 3 reviewers, so it's a little different. But we run some statistical analysis on the scores, average, median, and average without high and low. They take a look at those and they react to it. They respond to it. Then they have an opportunity to rank the organizations, the applications, the proposals, top to bottom. That does not mean that the one at the top gets the most money and the one at the bottom gets the least money. It's just one more tool. So first you have the scoring that you do individually. Then you have the program review, the positives and concerns. You take a look at the statistical analysis, and then you use ranking as a tool. And then the fourth is then making the recommendations for investment. In a United Way perspective, and from our vantage point, that's when dollars are shown. That's when we show how much has been asked for, how many dollars we have available, and what the difference is. And then the process works that way. I'm not sure that that process would necessarily work for the city process for a number of different reasons. One, we divide all of ours out in terms of area. So the applications that are for emergency food assistance are all together. Rent utility assistance, they're all together, and those dollars are portioned out. Healthcare and prescription assistance, safety from domestic violence, early education, and so on. These aren't, and so that would make it incredibly difficult and would be a multi-day process. Also, with just a few reviewers, if you take the average without high and low out, it's just the middle score, which is the median. Also, within the RFP, everyone knows how much money is available already. In the United Way process, our programs don't know how much money is available because at that time we're still running campaign and those types of things. So I think there are some benefits in taking a look at the two processes, but I don't know that there would be any special need to have adoption of those other parts of the United Way grant review process at this point.
Thank you for reviewing it for us, though. I think it helps give some perspective and some thought about alternatives. Is there anybody on the committee that would like to have maybe a print copy of that United Way process just to be able to review? One, maybe you could send it to Liz and she could get it out to us. Brett, thank you.
Certainly.
All right, we've covered a lot of ground. We've brought up our base. It sounds like we do need another meeting, and the committee needs to take all the input that we've had in mind, really look at the application, at the priorities sheet and how we frame what we are wanting to do, not necessarily the categories. Those seem to have some consensus, but look again at what we say in that mission line, look at the application form, and look at the scoring sheet with in mind the conversation that we've had. Staff, be it our consultant or our city staff, if you have any specifics that you'd want to provide for us to help us along the way, we'd be happy to have it. And then if we need to wrap up if possible so that we knew we might need a third meeting. I'm hopeful that maybe we can finish in one more. Any sense of, we're all just kind of cut loose after the election, right? Any 2 weeks, 3 weeks? What are you looking at, committee members?
2 weeks out.
2 weeks out. That would look like maybe the 12th of November, 10 to 12, possible? United Way?
I'm good.
Pardon?
I said I would be good with that, Chair.
Okay.
I've got 3 things that day already.
Okay, Mike has 3 things that day already.
I would not be able to meet on that day.
On the 12th? What about the, I don't know how the holidays are going for folks. What about the 11th? Are people working? Oh, the city's closed. Never mind. Friday the 13th?
Oh, that's ominous. How about a week later on the 18th?
On the 18th. I can make that happen. 18th, Wednesday the 18th, 10 to 12?
Yes.
Yes? Yes? Yes?
Yes.
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 Okay, Wednesday the 18th, 10 to 12. Any final comments? Thank you all. We're adjourned.
Thank you, everyone.
Thank you. So long.